Okay, thank you very much for the invitation, and a very good afternoon from here in Dubai. I know people are joining from different parts of the world. So in order to just warm up the session, I thought I'll just put this question. I can see very few audiences here. I'm not sure if this is the appropriate question to put. Anyways, so the question is, which of the following statements are correct? One, all patients above 30 with diabetes should be on statin. Calculated cardiovascular risk score above 10% is high risk. Atorvastatin 20 milligram is high intensity statin therapy. Number 4, rosuvastatin 20 milligram is high intensity statin therapy. Number 5, clinical outcome is not dependent on type and strength of statin you choose. And last, number 6, you should stop statin therapy immediately as the liver enzymes start to go up. So 30 seconds, any volunteer to answer this question?
I'll go with number 3.
Number 3, atorvastatin is high intensity statin. Any other answer? Okay, in interest of time, I'll move on. So in fact, it is rosuvastatin 20 milligram, which is considered high intensity statin. Atorvastatin 20 milligram will be a low potent statin. Okay, so up till recently and even now, the doctors have been treating dyslipidemia, or more so I would say the cholesterol. Initially, it was just the cholesterol level we used to check, and that is how we based our treatment plan or decisions. And then we started to check lipid profile in patients. And then our focus was mainly on the LDL level. We looked at the LDL level and then we gave therapy. But now the whole paradigm has shifted as to how we manage dyslipidemia. And it is all based on cardiovascular risk calculation or assessment. So in the next 30 minutes or so, I'm going to discuss dyslipidemia and cardiovascular risk that is associated. I'll be talking about how we choose statin therapy based on individual cardiovascular risk. And I'll just talk just a couple of practical guidelines. So as you know, the prevalence of cardiovascular disease is quite high, and it's nearing almost 500 million, and it is still increasing. And over the recent past, as you'll see, the prevalence has dramatically increased in some of the countries such as South Asian countries, India, Pakistan, Bangladesh, and so on, sub-Saharan African countries, South and Central American countries, but more so where we are now is the Middle East and the North Africa, where the prevalence of cardiovascular disease has gone up by at least 119%, and it's still rising. So what is the problem in this part of the world? Now, this part of the world, certainly, as you all know, is the hub of diabetes mellitus. The prevalence of diabetes is certainly high, both in adults and in children. And the obesity is not behind. 1/3 of Abu Dhabi population, and sure, for Dubai and other Gulf countries, the prevalence is quite high as far as the obesity is concerned. Now, what we are talking today is dyslipidemia. And as you can see here, at least half of the patients who have dyslipidemia are not reaching their LDL target goal. And more sadly, the figures that you see, 45% of the deaths in young Gulf population is attributed to cardiovascular disease. So more and more young people in this part of the world are dying because of the cardiovascular disease. Now, dyslipidemia, as I said, is highly prevalent, but yet people are not treating it adequately, meaning thereby we are not meeting those target goals. Now, if I talk about the primary prevention for cardiovascular disease, there are only 41% are not reaching their target goals of LDL. And in terms of secondary prevention, 68% are not reaching their target goals of LDL control. And this comes from the SAFER study that was done a few years back. And this study was done in 6 Gulf countries. So it's a local study, basically. Now, we all know that high cholesterol is a modifiable risk, modifiable because we can control it, we can do something about it to reduce the cardiovascular risk and the cardiovascular outcome. And there's a strong link, we know this from medical school, that high cholesterol indeed leads to atherosclerosis, and this leads to myocardial infarction and stroke. And as you can see here in the diagram, higher the LDL level, higher is the increase in the proportion of cardiovascular disease. And up till recently, we saw that lower was better, which means that lower the LDL level, better was the clinical outcomes as far as the reduction in the stroke or the myocardial infarction is concerned. Now, a lot of guidelines, adult treatment panel guidelines over a decade, looked at LDL level, and the goal was less than 100 milligram per deciliter. But more recently, the guidelines have changed, and mainly it is the American Heart Association and the American College of Cardiology. They have come up with a different way of looking at these patients. So they are targeting the patients who are at high risk, moderate risk, high risk, I should say intermediate risk, high risk, or very high risk. And it is on these categories, your LDL level should be looked at, and that's the way the treatment should be devised. Though we always thought that 90 to 130 milligram deciliter of LDL cholesterol was fine, and it was kind of, in inverted commas, considered normal LDL levels. But that is not the physiological normal levels of LDL. So we know a bit of more of pathophysiology, what LDL does to us and what it does inside the arteries, particularly the coronary arteries and the cerebral arteries. Now, the new paradigm is to bring down the LDL level to lower threshold so that we can improve things inside the arteries, such as improvement in inflammation of endothelial function will be seen if the LDL level is brought down below 80 milligram per deciliter. And if you want to stop the atherosclerosis progression, then your LDL level has to be even lower than that, less than 67 milligram per deciliter. And if you want to target primary prevention of cardiovascular events, then it has to be lower. And if you're targeting secondary prevention of cardiovascular events, then the LDL level has to be as low as less than 30 milligrams per deciliter. Now, intensive LDL reduction has shown that there is definitely cardiovascular improvement. So lower is the better. That's what we have this slogan now. Lower is the better. Lower the LDL level significantly lowers your risk of major cardiovascular events. Now, this is from a meta-analysis of 19 randomized control trials, which has shown that statins in the primary prevention leads to at least 23% reduction in myocardial infarction, 12% reduction in stroke. It leads to also a 16% reduction in revascularization procedure, and also reduction in 15% reduction in major cardiovascular event. And the most prominent figure that you see is the reduction in myocardial infarction mortality, which is whopping 54% reduction just by the use of a statin therapy and control the lipids to the lowest possible level as per the guidelines. Now, I was talking about the lower is better. So what is earlier is better? Now, there is a paradigm shift. We talked about lower the better. Now, it's a time to also add that earlier is the better. So what we have a slogan now is the earlier and lower the better. So as you all know that the atherosclerotic process starts quite at a young age, as early as 10 years of age, and hence the primary prevention is very important to catch those patients who are at risk of developing cardiovascular disease in the future. And some of them, as you know, they're developing heart attack and stroke in their 30s, 40s, 50s. So the primary focus is now going to be target the LDL levels and not only decrease them to the lowest levels as per the guidelines, but also to act upon it early and treat the LDL levels as early as possible. Because the 2/3 of the major adverse cardiac events, they occur in individuals without prior vascular disease. So there will be people in the audience, who will be healthy, but if they have got high cholesterol, high LDL levels, then certainly they are at risk of developing vascular disease in the near future. And it is also said that 61% of men and 49% of women, if they are above the age of 65, I think the figure is probably even lower than that, have got subclinical cardiovascular disease. So cardiovascular risk assessment, that is my main topic that I'm going to discuss. So why do we need cardiovascular risk assessment? And so cardiovascular risk assessment is important to reduce the incidence of cardiovascular disease. And also it would help to devise the management plan that will improve the quality of life and also increase the life expectancy. So the whole paradigm shift is that don't look at the cholesterol level, not only at the LDL level, but each individual has got to be assessed individually, putting in all the parameters of the risk factors, his age, the ethnic background, the diabetes status, high blood pressure control, weight, smoking history, family history, and so on. So I'm not going into the details of how we do the cardiovascular risk assessment, because that is again a chapter in itself or a talk in itself. So the guidelines that we have seen over the last few years, they have come from American College of Cardiology, American Heart Association, European Society of Cardiology, mainly. And so there's two approaches by the American side and the European counterpart. But I personally feel that the American College of Cardiology and American Heart Association guidelines, they seem to be more practical because they have grouped the risk categories just in 4 groups. So there are 4 risk group categories, which I'll discuss now, and how you're going to target and reduce the LDL levels in these risk categories. And before I move on as to how we choose the patients and treat them with statin therapy, you must understand, because I put one of the questions in the one question, and that there were a few options. So what is the intensity of statin therapy? And that is essentially based on as to what is the percentage of LDL that particular statin can bring it down to. So high intensity statin has got a potential to decrease your LDL level by 50%. And there are 2 dosage of these 2 statins, atorvastatin 40 or 80 milligrams, or rosuvastatin 20 milligrams or 40 milligrams. And moderate intensity statin are those statins that will bring down your LDL level anything from 30% to 50%. And these are the statins and their dosage that are mentioned in the middle panel. And the low intensity statins are those statins that bring down your LDL level to less than 30 milligram per deciliter. And these are the statins: simvastatin 10 milligram, pravastatin 10 to 20, lovastatin, fluvastatin, and pitavastatin. Now you may ask, is there any role for the low intensity statin? So the answer is yes. And why the answer is yes? Because there are patients who do not tolerate high intensity statin. Sometimes they even do not tolerate moderate intensity statin. So simvastatin, as per guidelines, is kind of almost out of the guidelines. So nobody uses simvastatin in the current era. But pravastatin, yes, lovastatin I use, fluvastatin I use in my patient, pitavastatin I've got few patients. So these are the statins that are still in use, although they are low intensity, but they are again reserved for a specific group of patients who do not tolerate moderate or high intensity statins. Now I'll just discuss very quickly as to how these guidelines, American College of Cardiology and American Heart Association, they focus on the use of statin as the first-line therapy and what the appropriate intensity of statin therapy should be in the 4 groups that I'm just going to show you now. So the 4 groups are essentially the first group are the patients who have got established atherosclerotic cardiovascular disease, means they already have suffered myocardial infarction or stroke, or they have got angina, or they have had transient ischemic attack, or their LDL level is more than 190 milligram per deciliter. If you convert it into millimoles, it will be more than 4.9 millimole per liter. Or if they are diabetic between the ages of 40 to 75 with LDL cholesterol level of 70 to 189 milligram per deciliter. and their estimated 10-year atherosclerotic cardiovascular risk is more than 7.5%. Then there's another category of diabetic patients with similar parameters, but the calculated risk is less than 7.5%. And then there is another category, which I would say is the fourth or the fifth category, where the patients are quite healthy, so to say. They do not have established cardiovascular disease. They are not diabetic. But if you calculate the risk for these individuals, their LDL level may be between 70 to 189 milligram. But the calculated risk is again more than 7.5%. 7.5% to have any cardiovascular event in the next 10 years. So statin benefit groups. So if the patients have got established atherosclerotic cardiovascular disease and then they are less than 75 years. So these guidelines do not apply for people who are above 75 years. That you should keep in mind. So here you're going to use high intensity statin. And as I said already, these are the patients who already have got established cardiovascular disease. They have suffered myocardial infarction. They have stable or unstable angina. They have undergone revascularization. They had severe stroke or TIA, or they have got peripheral vascular disease. Now, the second statin benefit group are the patients who are above the age of 21 years, but less than 75, who have got very high LDL level, where the LDL is more than 190 milligram per deciliter or more than 4.9 millimole per liter. Here again, you're going to use high intensity statin. The third category are those patients who are diabetic and between the ages of 40 to 75. And if the calculated risk is more than 7.5% for the 10 years atherosclerotic risk, then you have to use high intensity statin. If the risk is less than 7.5%, then you can use moderate intensity statin. The patients who are diabetic, and if the estimated risk is more than 7.5%, then you use moderate to high intensity statin. But if the estimated risk is less than 7.5%, then you just advise them lifestyle changes, regular physical exercises, and good diet control, low fat and low cholesterol diet. Now, I've got just a few cases to run through, and very quickly I'll go through these. Case one is 62 years old Afro-American male, total cholesterol of 140 milligram per deciliter. So you can just read these figures. I'm not going to go all the details. And then the calculated 10-year risk is 9.1%. Now, which category you're going to put this patient in, and what will you use? Will you use intermediate, moderate intensity, or high intensity statin? Sorry. So here you're going to use moderate to high intensity statin. And sorry, I think I'm going to skip this slide. I'm not sure how many people, in the lack of time, I'll just skip this actually. It is supposed to be more interactive. That's why it's not much of use if I continue like this. Okay. Now, so the second part is now we have used medications, and statin is the commonest drug that we use for LDL lowering. And we get a lot of patients where the LDL is not at target, or the patients may be statin intolerant. So what is the next step? So you have used statin, you have used it to the maximum dose, you have titrated it up to the maximum dose of statin, where the statin could be tolerated. So what is next? And I'm sure people know these two molecules. Ezetimibe has been there for a number of years. PCSK-9 inhibitors, again, has been here for a good few years now, but relatively new to some doctors. Now, Ezetimibe is again a cholesterol-lowering drug, and it inhibits sterol transport in the brush border of the gut, and therefore it reduces the intestinal absorption of cholesterol and decreases its delivery to the liver. Now, as you can see here, the diagram on the right, on my right, and so if you have used statins, you have increased the dose or titrated up the dose to the maximum dose or the maximum tolerated, that is shown in the blue. And what you do if you add Ezetimibe, and you can see the percentage of reduction or the change, percent change of the LDL level from the baseline. It's almost 28%. And if you have used atorvastatin to the up-titrated dose, and you see the LDL reduction of almost 9% or 10%, but if you use or add ezetimibe, then there is a significant reduction in the LDL levels, 27%. Likewise, if you're using rosuvastatin, this is the reduction in LDL, but when you combine it with ezetimibe, then there's a very significant reduction in the LDL level. Now, moving on to PCSK9, just one or two slides. Now, PCSK9 inhibitor is a relatively new drug. Mind you, it's not available in oral form. It is to be given subcutaneously. So these are injections. And that is one of the reasons it did not become very popular. The second reason it did not become popular is these drugs are very costly. So it is not for routine use, but these drugs are reserved for people who have used all means, the statin, the first line, second line, ezetimibe, and of course, do not forget the lifestyle and the exercise or the diet control is the first line, I would say. Then is the statin, third is the ezetimibe, and this is kind of a fourth line. Now, PCSK9, basically, these are the molecules that attack the LDL receptors here, the bind to the LDL receptors. And what happens that the LDL, they cannot, and these LDL receptors on the liver cells or hepatic cells. And what happens, they prevent the LDL to bind to these LDL receptors and leading to the LDL floating around in the bloodstream. So the blood levels of LDL, they are quite high. So PCSK9 inhibitor, as the name suggests, inhibitor, it inhibits this PCSK9, it blocks these PCSK9 molecule. And therefore, this allows the LDL to bind to these LDL receptors on the liver cells. And therefore, it decreases the LDL level significantly. More than 60% of LDL reduction can be achieved using PCSK9 inhibitors. So in the market, there are mainly two, but there are a few more in the pipeline. So it is the alirocumab and there is evolocumab. So these are the two PCSK9 inhibitors we have. And FDA have got approved indication, familial hypercholesterolemia, primary hyperlipidemia, and secondary prevention of cardiovascular events. And these are the doses that are mentioned here. Now, I'm not going to go through this, but just to tell you in a nutshell that if you do not have LDL control at target, then obviously you need to obviously focus, that is the key, focus on the patient's lifestyle, make sure that they are exercising regularly, they are controlling their diet adequately, and give all the advice. It's just not important and not enough to say, okay, go and eat low cholesterol diet and low fat diet, but there must be some kind of arrangement. There should be involvement of the dietitian, and these patients need to be followed up quite regularly, sometimes very rigorously in terms of managing their weight as well as the fat content. You may make use of some devices where the fat can be estimated, the body fat particularly, because that again increases the cardiovascular risk. Now, if they are not a target, then obviously you've got to start with statin. If you have used the statin to the maximum dose, or if the patients are not tolerating statin, then you add or switch to ezetimibe. And if that fails, then obviously you're going to use or add PCSK9 inhibitor. And higher the risk, you have got to be more aggressive in your approach in controlling the LDL levels. Now, just the second part of my talk very quickly. I've got, I think, 5 minutes. So which of the following are true? And these are some of the questions. I'm not going to go through again because I wanted this to be interactive. So moving on to my second part in next 5 minutes. So we know that the statin, they target mainly the LDL, and the LDL lowering with statin reduces cardiovascular risk. But we should not forget that still there is a substantial residual risk that still remains. And where does this risk come from? So this risk actually comes from the non-LDL cholesterol, which includes your VLDL, chylomicrons, and also low HDL levels and lipoprotein A. So these are the few things we do not test routinely, but these must not be forgotten. And the meta-analysis has very clearly shown, these are from the 21 randomized control trials, that 78% of the risk of major cardiovascular events are still unaddressed. So we tend to ignore a larger population where they are still at risk. And these may be due to the non-LDL cholesterol levels. Now, the non-HDL cholesterol 2020 AAC guidelines now very clearly states that it is not always the LDL that you should target. You've got to look at the non-LDL cholesterol, Apo-B, and the triglycerides as well. Triglycerides now has been shown to be an independent risk factor for cardiovascular disease, and higher your triglyceride level, particularly if it is above 200 milligram per deciliter, it does put you at risk of developing early cardiovascular disease, both stroke and myocardial infarction. But anything goes beyond 500, you are at risk of developing acute pancreatitis. Now, fibrates, they have shown to decrease your triglycerides by 25 to 50%, and omega-3 fatty acid up to 45%. And these are some of the trials I'll show you in the next slide. So the two trials, the field trial and the accord trial, that have been done using fenofibrates, and that have shown if your triglyceride level is at a borderline, like 1.7 millimole per liter, then you're not going to benefit much. But once this triglyceride goes beyond 2.3 millimole or more than 200 milligram per deciliter, then both the trials have shown a significant reduction in cardiovascular events and also cardiovascular death. So omega-3 acid, fatty acids, so these are not the fish oil supplement that you get in the market. So these are highly packed, very refined fish oil, omega-3. And if you're going to target to decrease the triglyceride, then you've got to use in appropriate dose. And the therapy dose, the maximum dose you can use is 4 grams daily, which is 2 grams twice a day. And that has shown to reduce your triglyceride level significantly with or without use of statin therapy at the same time. And the reduce it is the landmark trial that has been done with using the fish oil, omega-3 fatty acid, and compared to placebo, it led to a massive 25% relative risk reduction in the primary outcome in this study: cardiovascular death, myocardial infarction, stroke, coronary revascularization, and unstable angina. Now, my last thing I'm going to touch upon is the lipoprotein A. So now if you ask, I ask the audience about lipoprotein A, many physicians or cardiologists, they do not know and they do not routinely test lipoprotein A. So lipoprotein A basically is a small molecule. It's a type of LDL cholesterol. You can say is a component of LDL cholesterol, and it is highly prevalent. And you'll be surprised if I say that 1 in 5 individuals, if we are 5 here, I think one of them has got high lipoprotein A. So it is very, very high prevalent, but it is not much recognized molecule. And why lipoprotein A is important? Because it is an independent risk factor for developing not only cardiovascular disease, but premature cardiovascular disease. So lipoprotein, if somebody has got high levels of lipoprotein A in their blood, then they are at risk of developing heart attack or stroke, even in their 30s or 40s. So that is the important message I need to give, that if you have not checked your lipoprotein A, then please check it. It is always advisable to check it once in a lifetime because the prevalence is very, very high and it is still not very well recognized. And if somebody has got a strong family history of premature coronary artery disease, then certainly they should check the lipoprotein A. If there is history of familial hypercholesterolemia, or if there is history of family history of lipoprotein A, if somebody has got a family member whose lipoprotein A is high, then it even becomes more important to check for it. And if the patients are statin resistant, if you see a patient with high cholesterol, high LDL level, and you have used statin, and you have used statin to the maximum tolerated dose, and you still see that the LDL level is not decreasing, you're not able to get it to a target, you may have used even the Ezetimibe or even the PCSK-9. And once you start to suspect that they may be statin resistant, then please check for lipoprotein A in these patients. So if you ask me what is the therapy for lipoprotein A in the current era, there is none. So a lot of the treatment, particularly in the lower panel, you see they are all experimental. And so there is no treatment for lipoprotein A. One of the treatments may work is just the apheresis or plasmapheresis, just to remove these molecules as we do it in a dialysis. But certainly there is no therapy But again, there are a few treatments, as you can see, they are research based treatment. And hopefully in the next few years, we should find some treatment for that. So what do you do when you get a patient with high lipoprotein A? Then certainly these patients should be on aspirin. And also you start them on good dose of high intensity statin therapy. PCSK-9 again is not practical for these patients. So finally, we discussed the lipid lowering therapy, and statin for some unknown reason is the most feared molecule of this century, I would say. And there are a lot of negative criticisms about statin, but certainly we must ensure that our patients understand their cholesterol levels, how they are risk stratified, and what the treatment options are available. Particularly the patients, I'm sure you see, they fear statin molecule for some reason. So we have got to make them aware that these are the statins. We do not give them to cause side effects, but we give them to protect them from having a heart attack or stroke. So finally, I would finish with these take-home messages. Dyslipidemia is an important cardiovascular risk factor. Total cardiovascular risk must be assessed for each patient. Choice and dose of statin therapy must be based on cardiovascular risk. It should not be on a traditional way, which we have been doing for many years. And most importantly, we must spend some time at least to educate our patients and teach them why statin therapy, why lipid lowering is important, and why statin therapy is safe for them to use. So with that, I thank you very much for your patient listening. And if there is any question, I'm ready to take. Thank you.
I have a question related to last point that patient education is important. I found in normal life that people under 30 years are very reluctant to be treated with statins. Why? Because they feel well. They are sport practices. They are people who deals with many things with no problem. So sometimes I find them that at the beginning, at the early birth, there's strips, lipid strips in the arteries. So dyslipidemia is a treatment that has been treated from the early, but how do you do? My question.
Yeah. No, I think that's a very valid question. I would say more of a comment, and certainly education is important. For two reasons. As you said, that patients come to us mainly with symptoms. So they're very much symptom driven, and they seek treatment mainly to get their symptom under control. That's a fact. They do not know much about that this statin or any therapy is going to protect them from having a heart attack or stroke in the future, or even help them live longer. So as a physician, it becomes our moral duty that we teach our patients that, first of all, why cholesterol treatment is important, what cholesterol does in your body, right from the age of even if you are younger as a kid. And as you say, I sometimes show them a model of the artery where the atherosclerotic plaque is there, and that develops with age, how it kind of increases, progresses, and then clogs up the artery. So once we demonstrate, probably we make an effort to make them understand what cholesterol can do. And then we advise statin therapy, then perhaps I think they will be more acceptable. They'll accept the treatment. At the same time, there's a lot of negative criticism in the social media particularly. And a lot of people, they meet Dr. Google before they see the real doctor. So again, there's a lot of things in the social media, on the Google, on the internet, against this statin therapy. And anybody can stand on, they've got a mobile camera and they can shoot any video and they can say they are this and this. But the fact is that they may not be true, but they also risky business for the patients. Any other? Sure.
I would just general observation. It comes to the, I'm also taking holiday earlier medication at the West State, and so when I go to the doctor, like physician, right? So okay, start 40 milligrams, right? the nose that like right at rest in the US. And that tests are like in example, we can find the trouble goes half, but it is more potent. But also there is general perception, right? If you take garlic, for example, garlic, it also lowers cholesterol, right? With exercise, with the with the diet control, right? With the not eat too much meat and all those, more of the vegetable, other things. It can also lower the cholesterol. There are so many other things, prevention, right? But even after I see some physicians, they're also very reluctant to take it. Because there's always stigma attached to the physicians that will be kind doctor prescribe why I should take it. Is that your also perception sometimes?
Yeah, I think you're very right. Like a lot of things are there which are not evidence-based because obviously no research has been done. So we don't have data. So that is something when patients ask me, say, for example, garlic or any other thing. So I say I don't have a scientific backup to suggest or promote or give you advice on that. But if it helps and if it does not cause any harm, then it is absolutely okay to take.
Right.
So I think what we should be looking at that it should not harm the patient, first of all.
Right.
They may take X, Y, Z, so long it does not harm the patient. I think it should be absolutely okay. Garlic, I'm sure it helps, but unfortunately, we do not have any scientific evidence. Yeah. Likewise, if you see the diabetes control, there is the beta gourd. And beta gourd, when I did some research, there are some good studies with beta gourd, and they do help in reduction of sugar. So that is I advise my patients, along with the lifestyle change, I say just take these before I start you on treatment.
Good presentation. I like it.
Thank you. Anything from there?